Hi, I'm Stephanie Hertz, Marketing Director here at Warwick Forest, the premier sponsor of CNU's Lifelong Learning Society. Today, I'll be introducing two Riverside Health System Neurointerventional Specialists. But first, I wanted to tell you a little bit about where I'm filming from. I'm in our newly renovated movie theater that has super comfortable reclining chairs and state-of-the-art surround sound that our residents enjoy regularly with fresh pop popcorn and snacks and our matinee and evening showings. The first neurointerventional specialist is Kaylee Zapata. She is a family nurse practitioner, board certified by the American Association of Nurse Practitioners, who specializes in stroke and neurointervention at Riverside Regional Medical Center, the peninsula's first and only comprehensive stroke center. Her background includes over 12 years of experience as an emergency room nurse who is specialty trained in TNCC and ENPC trauma support, with a specialty certification as a certified emergency room nurse. Kaylee is also recognized for her prior military service in the United States Navy aboard the aircraft carrier USS Dwight D. Eisenhower, serving and supporting the Iraq War. She obtained her undergraduate degree from Liberty University in Lynchburg, Virginia, and obtained her master's degree from Chamberlain University in Chicago, Illinois. In her free time, she enjoys spending time with her husband, son, and 3 dogs, as well as enjoying musical arts, cooking, and exercising. The second neurointerventional specialist that will be speaking today is Jatifha Harris. Jatifha earned a Bachelor of Science in Nursing from Russell Sage College in 2010. She later earned a Master of Science in Nursing from Liberty University in 2016, followed by a postmaster's certificate in Adult Gerontological Acute Care in 2018. Jatifha is board certified as an Adult Gerontological Acute Care Nurse Practitioner by the American Association of Critical Care Nurses Certification Corporation. Jatifha has enjoyed spending the bulk of her nursing career practicing and serving as a nurse educator in the fields of neurocritical and pulmonary critical care medicine. Now, as a nurse practitioner, she'll be using her experience in specialized training to provide interventional or inpatient neurovascular and neurointerventional care at Riverside Regional Medical Center. Passionate about practicing medicine, Jatifha truly enjoys taking care of patients and being a part of a patient-focused team. Born in Queens, New York, and raised in Brooklyn, Jatifha now enjoys Hampton Roads for its beaches, shopping, and restaurants. In her free time, she also enjoys music and traveling to new places. Jatifha is the mother of 1 son. Now please welcome Kaylee Zapata and Jatifha Harris as they speak about stroke education and the stroke program at Riverside.
Hi, my name is Jay. I'm one of the nurse practitioners here. Today, Kaylee and I were both supposed to present, but based on patient care, it was a little difficult for us to both step away from service. So while Kaylee is still serving our patients, I decided to come over and still be able to provide the information for today's presentation. Like they said, I'm Jay. I also am known as Jatifha Harris, but everyone calls me Jay. So I'll get started. Okay, so like I said, we are a comprehensive stroke center here. My name is Jay. This is my information here. I work on the neurovascular, neurointervention, and stroke neurology service. The goal of today's presentation is primarily to help everyone understand what the different types of stroke are, to identify some stroke risk factors and warning signs of stroke. We commonly use BEFAST, and later on in the presentation, I'll go through those a little bit more in depth. Understand the importance of time is brain, what we do in after stroke care, identifying reputable sources for stroke survivors and for patients and families both. And for information about stroke education, we want to make sure you're using reputable sources at all times. So who are we? Riverside Regional Medical Center is a comprehensive stroke center. We are one of only 6 CSCs in the state and the only one in the southeastern Virginia. We are a stroke program that is dedicated and committed to a higher standard of clinical service. We have recently been the recipient of the Paul Coverdell Acute Stroke Program grant. And with this grant, we will share expertise with other hospitals throughout the state. We will serve as a model to all Virginia hospitals and partner with the Virginia Department of Health to ensure that we are meeting the key outcomes and goals throughout grant activities. With this grant, we will collect and measure track data to improve the quality of care for our stroke patients. With the guidelines, we are a Gold Plus award recipient for 2021, and this recognition allows hospitals to be acknowledged for their compliance with the quality measures within the Get With the Guidelines program. It's an optional award that the hospital chooses to pursue when we are collecting quality measures, and we want to be recognized for our efforts. So in order to achieve this, we maintain at least 75% compliance for 12 consecutive months, and for 5 or more select quality measures. Within our multidisciplinary team, primarily there are Dr. Amakrishnan and Dr. Leash, who are our attendings. Kaylee and myself, we are the nurse practitioners, but beyond us, we have a huge team of nurse practitioners, physicians, radiology technicians, CT, MRI, echo department. So in order for us to provide great care for our patients, we need the assistance of all of the members of our healthcare team. So some quick stroke fast facts. Nationally, stroke is the #5 cause of death and leading cause of disability in the United States. It is the #4 cause of death in women. Every 40 seconds, someone suffers a stroke. Every 40 seconds, someone suffers a stroke, and every 4 minutes, someone may die from a stroke. In the U.S. alone, 795,000 people have a stroke every single year, and in about 185,000 of those, about 1 in every 4, those people have already experienced a stroke. 80% of strokes are preventable, and that's what we're going to spend some time talking about today. What things can we do as individuals to prevent stroke in ourselves and in our loved ones? 34% of patients who suffer a stroke are less than 65 years old. So there is a common misperception that patients who suffer strokes are always elderly, but that is not the truth. We are seeing more patients have strokes who are younger than 65 and sometimes even less than 50. So it is an important, thing to think about and a disease to understand in all ages. African Americans are twice as likely to suffer a stroke, and based on socioeconomic status, individuals with lower status are more likely to suffer a stroke. So here in Virginia, stroke is the #4 cause of death. About 3,300 stroke-related deaths occur every year in Virginia. That's about 1 in 20 people. Every 50 minutes, someone has a stroke, so nearly once every hour, someone may have one. And every 2.5 hours, someone dies from a stroke. 17,000 people have suffered a first-time stroke every year, and 26,000 people have a recurrent stroke. So $880 million are spent in stroke-related inpatient hospital charges, and those are just the charges that are incurred from a patient being in the hospital. That does not include the post-hospital phase, so rehab, home health therapy, ongoing appointments, and follow-up. So it is a huge, huge, huge burden on our healthcare system financially, so we want to do everything we can to prevent it. This slide here, I'm sure that in previous stroke presentations you have seen it, and it is one that is pretty common. The CDC has released this map here, and it shows exactly how stroke deaths are dispersed across the United States. Where you see the darker purple is considered the stroke belt. It's in the southeastern U.S., and since the 1940s, this region has had a higher mortality of stroke. It is commonly known as the stroke belt, like I just said, and some research has been done to understand why exactly this area is more likely to have strokes. And if you see here, if you really pay attention, Virginia is right kind of capturing the top portion of it, but it's really the southern eastern states. Some factors that contribute to the stroke belt area are large proportion of minorities, higher prevalence of stroke risk factors, lower socioeconomic status, and different healthcare disparities, as well as, the way we eat down in the South. Some of that good down South cooking probably does not lend to help this stroke belt. In this area, 18% higher incidence rate and higher risk of the typical low risk groups like those who are under 50 suffer a stroke. Within this area, there's also a less commonly known area called the stroke buckle, and it is pretty much the coastal area of the southeastern states. So again, looking at this map, there's a lot of work to be done in our area and in the southern eastern states. So what is a stroke? There are ischemic strokes, which are blockages in the brain, likely caused by an embolus or a thrombus. Those make up about 87%. So the majority of strokes that occur are going to be from blockages within the blood vessels. Hemorrhagic strokes, bleeding types of strokes, those only make up for 13% of strokes, but they can be just as debilitating, if not more, than ischemic strokes. And there are two different kinds of hemorrhagic strokes. There are subarachnoid hemorrhages and intracerebral hemorrhages. And TIAs, class of its own, not a mini stroke, but is a warning sign of a stroke. And if a patient has a TIA, they are 12% of those patients are likely to go on to have a stroke following that TIA. This picture here just lets us know all of the different things that the brain is responsible for. And this is just some of them. Each part of the brain is responsible for something different. And when you come into the hospital, these are the things that are at risk when you suffer a stroke. And we'll get more into those. So what is an ischemic stroke? An ischemic stroke makes up about 87% of all strokes. It occurs where there's a blockage of blood that delivers oxygen and blood and oxygen to a portion of the brain or to the brain itself. When that specific vessel is blocked off, that area of the brain starves from not receiving blood and oxygen. There are two different types of blockages that may occur. In the grand scheme of things, there are many reasons, but primarily blockages occur because of an embolus or because of a thrombus. An embolus is a clot that travels from the brain after it forms in another part of the body and then travels through the blood vessels and lands itself somewhere in the brain and causes a blockage. A thrombus is a clot that forms somewhere where there's fatty buildup. So patients who have higher cholesterol, where those cholesterol deposits occur, that area of the vessel or that plaque buildup can rupture and a piece of it can fly off and cause a patient to have a stroke within the vessel that travels to the brain. So those are the two types of ischemic stroke. So this picture here just kind of gives you an example of what we're looking at when we talk about an embolus, which is a blood clot at the top, or a plaque. And either one of those things can cause a blockage in the brain. And here you see towards the right of the screen where the vessel turns into a little bit of a V. We call that a bifurcation. But there's a blockage there. And where there's a blockage, blood and oxygen are not able to get delivered to that part of the body, that part of the brain, excuse me. Hemorrhagic strokes. So they make up a smaller portion of the number of patients we see with strokes, only about 13%, but they can still cause some of the same effects as an ischemic stroke. This type of stroke will occur when there is a weakening in the blood vessel and it ruptures and it bleeds. There are two types of these: intracerebral hemorrhages, meaning that there's bleeding within the brain tissue itself, and subarachnoid hemorrhages. This bleeding occurs in the space between the brain and the skull. This is where all the blood vessels are housed, and the cerebral spinal fluid keeps them all kind of suspended above the brain, but it helps the blood vessels deliver blood and oxygen to where it's supposed to go. If there is bleeding there, it's called a subarachnoid hemorrhage. There are different types of causes for hemorrhagic stroke, and they may include extremely high blood pressure, aneurysm ruptures, AVMs, which are abnormal nests of arteries and vessels that form and cause this little nest of blood vessels called an AVM, and underlying brain mass, and of course head trauma. So any of these can cause you to have a hemorrhagic stroke. So again, this is just a little bit of a picture to give you an idea of what we're talking about. On the lower right-hand side, that is where we talk about weakening of a blood vessel. So vessels can only withstand so much pressure at a point, just like any hose at a point or a balloon. If you blow it up, and you increase the pressure inside that balloon, at some point it may pop. And that is exactly what may happen in the blood vessels, causing you to have a bleeding type of stroke. On the top left, this is where we speak about aneurysms. So aneurysms are also, again, weakening of blood vessels. As the blood vessel weakens, there's a little bit of an outpouching or a bubble on the vessel that may occur. And again, if that pressure goes up and that bubble or the wall becomes too weak, it can burst. That occurs in this area here called the subarachnoid space. That's where all of the vessels are housed. So you have the skull, you have the dura, which kind of keeps everything in place, and you have the subarachnoid space. So in there, that is where these types of bleeds can occur and where we would find these types of aneurysms. What is a TIA? So many times we have patients come into the hospital and they will say, yes, I've had a mini stroke in the past. And that is not always helpful. A TIA and a stroke are very different things. A TIA is a warning sign of a stroke. It is your body's way of telling you something is not right. It is alerting you to go and get help, seek attention, and find out what is causing you to have these symptoms. 500,000 adults every year will have a TIA. A TIA occurs, and sometimes the symptoms may come and last minutes. They may last hours. They typically resolve within 24 hours, but because our technology is so good now, we are able to pick up a lot of these strokes if a patient has one, if they come in with symptoms very early. If we do certain types of scans, including an MRI, and we don't see any evidence of a stroke, but you had stroke-like symptoms that resolved, we would likely call that a TIA. It is not a mini stroke. If you have a stroke, there is evidence left behind that we can see on an MRI. If you do not, then it's a TIA, but they are both treated and managed the same way. We still would do the same workup. We would still do the same investigation because your body is telling you there is something here that is causing me to have problems. So there's a small blockage that occurs and you develop symptoms, the body gets rid of it, but you are still warned. So you come into the hospital. 9 to 17% of all TIA patients will go on to have a stroke within 90 days. So you have a warning sign of a stroke. My arm feels a little bit numb. I can't really lift it too much. It lasts maybe a couple minutes, maybe an hour, and then it goes away. You think nothing of it, but within 90 days, up to 17% of these types of patients will actually have a stroke. So it is considered a medical emergency. If you experience any stroke-like symptoms, whether they last minutes, hours, days, please come in as soon as possible. So stroke risk factors. What are risk factors? They are things that may cause an increased chance of developing a disease or a type of process. There are modifiable factors and there are non-modifiable risk factors. The modifiable ones are the things that you have control over, but they can raise and lower your chances of developing a disease. And then the non-modifiable risk factors are things that you may not be able to change. And although it may not be easy, lifestyle changes that we have control of are completely up to us. Non-modifiable risk factors. So age cannot do anything no matter how hard we may try to age backwards, it's not going to happen. So as you get older, of course, your risk for different diseases, including stroke, increase. Family history is one, race, and gender. And when we think family history, don't think just my mom had a stroke, my dad had a stroke, my sister had a stroke. Also think about some of those factors that go along with family history. Yes, as you have family members or people in your family who have certain diseases or certain disease processes, it does increase the risk within the family for you to have those risk factors. But think about what things, and some of those will be discussed in the modifiable risk factors, what types of things are happening within the family, including diet, sedentary lifestyle, that also may lend to some of the risk factors that you expect. So modifiable risk factors. These are things that we have control over. Many people with diabetes also have high blood pressure, high cholesterol, and are obese. And those are some of them listed here. So the modifiable risk factors are hypertension, diabetes, smoking, diet, sedentary lifestyle, obesity, high cholesterol, atrial fibrillation, and carotid and peripheral artery disease. Some things that don't help are diets that are high in saturated fat, trans fat. Cholesterol can raise these blood cholesterol levels. Foods high in sodium salt, can increase your blood pressure. Those with high calories can also lead to diabetes and obesity. But a diet that contains 5 or more servings of fruit and vegetables every day may reduce your risk of stroke. All the recommendations are for about 150 minutes of exercise per week. Just aim to move more, right? And sit less. When you're able to, take the stairs instead of the elevator if you can. when you park at the store, park a little bit further. You know, many people will try to get the first spot, you know, at the grocery store, but maybe park a little bit of the ways down and increase your walk then. Small increments of exercise add up. We count everything. And the more you move, the more you improve your risk, the more you decrease your risk of having a stroke. Large amounts of cholesterol can build up in the blood and cause you to have plaque buildup there. And this is also responsible for plaque buildup, not just in the arteries of what many people think of the heart, but also in the ones that feed and supply the brain itself. Atrial fibrillation. Although some people cannot help going into AFib, there are things that we can do to control AFib and medications that we can give to reduce the risk of having a stroke due to the AFib itself. Many AFib patients may also have sleep apnea. So if you have sleep apnea, it's something that you want to also control. Management of AFib may be performed by your cardiologist or your primary care doctor, and it's important that you follow up with your primary care team to make sure you are addressing and reducing the risk of all of these. So if you have hypertension, is your blood pressure controlled? Are you taking your blood pressure frequently and keeping a log? If you notice that it's no longer under control, contact your PCP. Come up with a plan that's going to work. Some people choose to do diet and exercise, and that's okay. But if those things don't work for you, then it's okay to work with your primary care doctor or your specialist team and find an approach that works to reduce your risk. Sorry about that. So what are the stroke warning signs? We like to use BEFAST. So B for balance, E for eyes, F for face, A for arm, S for speech, and T, time to call 911. So when we think balance, we think, is your balance unsteady? Do you get up to walk and notice that you're having a hard time keeping straight? Do you veer from one side to the other? Eyes, has your vision suddenly changed? Or are your eyes going to one way and not the other? So something as simple as someone talking to you and then all of a sudden their eyes go to the right and you call them and they can't move them to the left. That is a stroke sign. Or you're looking out in front of you or you go to eat a plate of food and you only see the left part of your plate and you notice that, or it's noticed that you left a portion of the food there that's directly half. Those are vision changes. Those are stroke warning signs. Is your face numb or asymmetric? Do you have drooping of the lip, or you're unable to control your secretions? Are you drooling? When you go to smile, is it uneven? Arm weakness or numbness. So these symptoms don't just mean your arm is not able to raise up and hold it up. So if you have someone who is experiencing that their arm is weak, simply ask them, hold up both arms in front of you. And if they're not able to maintain both arms at the same level and that's not their baseline, think stroke. If all of a sudden you're like, man, I really don't feel this side of my body so much, or they touch something hot and they don't notice it, again, that is something that you want to come in. But mainly weakness, numbness. If you are not able to raise your arms or legs equally, then come in. Speech difficulty. Not just being able to speak clearly. So many people associate slurred speech alone with a stroke symptom. But it's also not being able to speak correctly. So it's two components. How does it sound and what sense does it make? So if you ask someone to hand you a telephone and something that they're usually able to do and they're not quite understanding that, or they speak to you and the words are nonsensical, they are word salad. So normally they'd say, can you pass me that plate? And instead they say, can you touch the floor with the keyboard? It's like, that doesn't really make any sense. Those are things you worry about. You want to make sure you come in. You have any of these symptoms, balance, eyes, face, arm, speech are affected, immediately call 911. Do not drive to the hospital. Call EMS. That helps us get things in order for patients to come into the hospital. When you call 911 with stroke symptoms, we are alerted ahead of time, and the medical team is here and ready for you to come in and evaluate you and make sure that we provide you the best care we can as quickly as we can. So time is brain. So like I said, you find that you or your loved one has a symptom of stroke using BEFAST. You call 911 immediately. Common information that is going to be needed. When was this person last known well? That is not the same as when did it happen. Although those two things are important, they are very different. So we want to know, when were you or the person that you are calling for in their normal state of health and last seen, spoken to well. So if they were weak in their arm, you want to know when was the last time they were able to move that arm correctly. If they are slurring their speech, when is the last time you spoke to them and they sounded completely normal? Those are important. Then after you can tell me when were they last known well, then I want to know, well, when did it happen? Was it witnessed? You could have been at lunch and everything was going okay, and all of a sudden you notice that they slumped to one side. That is a witnessed onset, and that time counts too, but it's very important to understand the difference between the two. What is the medical history? We need to know things that even sometimes you think are not important, but we need to have clear information about your medical history in order to provide the best care for you. So any major conditions, hypertension, high blood pressure, hypertension, high cholesterol, diabetes, any heart disease, surgeries are very important. We always want to know, have you had any recent surgeries within the last few months? But you tell us everything that you can. Have you had any head trauma? All of those things are going to be important. Even the things sometimes you think are not are helpful to us to make good decisions. Another thing we need to know are medications. And sometimes, everyone does not always know their medications off the top of their head, but it's a very important thing for those of us or those of you who take medications. You should have a small list. Keep it somewhere where it's easily accessible. Many people like to keep things in their cell phone. Unfortunately, when you come into the hospital, we don't have your passcode. So we would say or suggest make sure you keep an easily accessible piece of paper in your wallet or somewhere where no one would need a passcode to get to it, but we could actually get to it quickly to see what your medications are. If you're unable to do that, at least know the big ones, mainly if you're taking any blood thinners. Some patients are on blood thinners or things like Plavix, aspirin, Xarelto, Coumadin, Eliquis. Those are all things that we need to know if a person is taken. And have an emergency contact. If you call 911 and you have your loved one transported, make sure they have your information, your name and your phone number. We are going to need to speak with you if the patient especially is not able to. This information is very crucial to us, and having to take the time to find information about a loved one is also taking away from time for managing our patients. Every minute that we wait, every minute that a patient is suffering a stroke, 2 million brain cells die. Okay, so that's about 120 million brain cells per hour. 93% of patients recognize numbness on one side of their body alone as a stroke. So almost the vast majority of them only had numbness as the primary reason that they were having a stroke. None of the slurred speech or the drifting from side to side or the weakness, numbness alone. And 38% of these patients were aware of major symptoms. So those are important things to keep in mind. So here is a slide called Save the Penumbra. So the penumbra is the area of brain that is able to be saved outside of the area of the brain that has already died from the stroke. So one thing that Dr. Christian usually uses is if a fire is set somewhere and you recognize that there is a fire, the time that you take to put the fire out, there's parts of the area that are going to be at risk, okay? But there's always going to be that central focus of where the fire started that's going to be irreversibly damaged. What we are trying to do is reduce the amount of damage that occurs from that fire. So the penumbra is the area of brain that is at risk but can be saved. So this image here shows you exactly what we mean. So on the top one is more orange area. That's the ischemic core. That means that part of the brain has been injured, has died, and we are not going to be able to save that. But the area around it, the more peach color with the word penumbra on it, that is the area that we are trying to eliminate from expanding and dying further. And if you look at the bottom picture, the black area is the core. That's where the primary stroke has occurred, and all of the blue is the area that's at risk. The longer you take to get here to the hospital or for us to give you treatment, is the higher that area is going to be going to succumb to stroke. So what we are trying to do is save all of the blue that you see there. The black, we're not going to be able to do anything about because that's when the fire starts. But we want to be able to put the fire out so it does not affect all of the blue. And that can happen as quickly as 2 hours and as quickly as 12 hours. So that's why we say time is brain. So some of the things that'll happen, you'll come into the hospital, it will be a lot of excitement. And for the sake of understanding why we do it to understand why we do it is to understand why we do it so quickly, right? So we have the ER staff that greets the patient at the door. They're getting information, pertinent information. What's the phone number? When did it start? Verifying your name, verifying your date of birth. And then the pharmacist is also going to be there to help us understand what medications you're taking and what things are going to be important for us to know. The medical staff are going to come in and evaluate you. The stroke team is going to be there. The radiology department is also going to be a part of it, but all of it is the diagnostic part of understanding why the stroke happened, or if you are actually having one, and if there is anything we can do immediately to save whatever penumbra we can. So individuals are evaluated for stroke. They may undergo an extensive workup, and we treat all the stroke patients when they come in the door, whether we know exactly if it's a TIA or a stroke. We don't know from when you hit the door. We just know you have stroke-like symptoms, and we want to be alerted immediately. The first test usually that's performed is called a CAT scan. That is to give us the first impression of your brain. We need to know immediately, is there blood there, or is there an area of brain that we already see that has succumbed to a stroke? This is our first glance at your brain. Aside from what you tell us and aside from what we assess, this portion of this information is very important for us to be able to determine what we need to be able to do next. There's also a test in similar location but different type of test. It's called a CTA, head and neck. If eligible, a patient will be able to receive this for us to look at the vessels that go from their heart up to their brain and to find out if there's any narrowing or any blockages or any abnormalities within those vessels. Not every patient is going to be eligible for a CTA head or neck for reasons such as kidney function or allergies to contrast or iodine. Those things are very important for us to know as well when you give us your medical history. If you are not able to undergo a CTA head and neck, then there may be other things that we do, but these are typically the first things that we do when you first come in. So this is just a quick picture of a CT scanner, and I'll explain why I put those pictures there, because a lot of times patients come in, this is the first thing that they have done, and then when we go down the line and we do more imaging, people believe, like, I've already had this done several times, but it's very important. It can be a very overwhelming thing to see initially when you come into the hospital, but understanding that most of the pictures that are taken here are done usually within a few minutes, and they are the quickest way we can look at your vessels and your brain. So these are just some pictures that we would get from a CAT scan or a CTA. On the top left, that is a picture of a relatively healthy brain where we don't see any blood. We see the things that we need to see, and that helps us determine what do we do next with the information you have provided us. On the bottom left, this is a picture of a CTA. It is not all-inclusive of what we see, but just a snapshot of one slice that is important for us to make sure that all the major vessels proximally, meaning more near to the middle of the brain, that they are open. And this is what we look for. We scan the entire head down to the top of the heart to look at all of those vessels. Now, when we get a CT and a CTA, these are also pictures that we see. This one shows us this one in the middle, the top middle. That one is a subarachnoid hemorrhage, where I said that that's where the bleeding occurs when there is a rupture of something like an aneurysm in the area of the brain that houses all the vessels. This is the typical pattern, or some of the times the typical pattern that we see in a subarachnoid hemorrhage. In the bottom middle picture, that arrow is pointing to what we would see as an aneurysm. In the top right picture, that is a blockage. Now, it may be a little difficult, and maybe I could have put them side by side, but if you compare that top right picture and you look at the bottom left picture, you will see that there's not a continuity of that vessel there. That lets us know that there is a blockage. That is an ischemic stroke. There's a blockage in your brain that we need to do something about if we are able to. So that's why, again, it's so important for us to get some of these pictures here that you see. And in the bottom right one, that is a typical picture, or one of a typical picture of an intracranial hemorrhage. So that is the one where there's bleeding directly into the brain tissue. All of these are things that we need to worry about, okay? But these are some of the very valuable information that we get when we have these types of images available to us. This is an MRI scanner, and I put this picture here so people can understand that an MRI scanner and a CT scanner, they do look a lot alike, but they do very different things. CAT scan is sensitive, but sometimes not as sensitive as an MRI scanner, and actually most of the time it's not. The MRI scanner does take a little bit more time. Some patients are not able to get an MRI if you've had metal implants or a pacemaker or shrapnel that's still in your body. These are some of the things that will not allow a patient to have an MRI, but this piece of equipment gives us very specific information. Sometimes the stroke may be too small to see on a CAT scan, and therefore we need to advance your studies a little bit more and get an MRI, and this is why it's important. This MRI can pick up strokes down to about 1 millimeter, if I'm not mistaken, or even ones that are as small as the nail of your finger, and sometimes those things are missed on a CAT scan. So we really rely on all of the diagnostic tools that we have here to make sure that we are doing the right thing for our patients. So again, just some general idea of what we see when we look at MRI images. Relatively, again, healthy brain or somewhat healthy brain on the far left. And this is just one of the many different types of images we get from MRI. The primary ones that we look at, there's about 4 to 6 of them that help us immediately, and then in more advanced diagnostics, the MRI is able to give us different sequences, that way we can see different things. If you are unable to get a CTA, the first one that we spoke about, that gives us a good picture of your vessels, for whatever reason you are ineligible, whether it's renal function or contrast allergy, iodine allergy, then we can get that same vessel imaging using an MRI. It does take a little bit more time, and you are required to be in the MRI scanner a little longer, but it is able to give us pictures. Our preference is a CTA because it's faster and the picture quality is so much better. But as you see here, we can still get a lot of the same information from what we call an MRA. It is a MR angiogram. So it gives us pictures of the vessels using the same MRI technology. And on the right side, you see this is what we look for when we see strokes. We use the different images or the different sequences to see, okay, this is what we see on one, we compare it to the next, and then that lets us know if there's an ischemic stroke. Down at the bottom right, that's an example of what blood may look like on an MRI. And on the middle, I guess, to the left of that is an area of a mass. So MRI is able to pick up a lot of things that maybe a CT scanner can't. So they're all important to us. A lot of times patients will say, I think I already had that done, but they are very different. And there may be times where we get one set of images and need to repeat it again. But again, it's all to make sure that we're doing the right things for you all. Some of the other diagnostic tests that we will do, cerebral angiography, that's some procedures that Dr. Leach, Dr. Ramakrishnan, also Dr. Kostov, who sometimes works on our team, they perform these tests where they go in and they take direct pictures of the vessels that feed the brain. It's usually a minimally invasive procedure. I do not perform them, but I am here to help take care of your patients when they come in for it. Echocardiogram. So consider the heart the main bypass for all things that go to the brain. We want to know if everything is right in the engine, okay? So a lot of times we'll recommend that you get an ultrasound of the heart, and that one is a surface. It's a probe that's taken and put on the outside of your chest, and it takes pictures using ultrasound to give us information about the way your heart is structured or the way that your heart is functioning. Does it function well? Does it pump the way it's supposed to? Are all of the doors closed that need to be closed, and are the ones that are opening well? That is primarily what we're looking for. And we want to know if there's a clot there or if there's any reason that you would form a clot in your heart. Again, we are looking for reasons for why you had the stroke. We identify why you had it, but part of our job is not to just diagnose it, but to investigate it. Consider us stroke private investigators, I suppose. So if you can't have an echocardiogram, the next thing would be possibly a transesophageal echocardiogram. Still takes pictures of your heart, but it's used by a different route, usually down the esophagus, but that helps us get pictures that are closer to the heart. It does not always give the same information as an echo, but sometimes it gives us better clarity because we're no longer having to look through the chest wall, through the rib cage, through the muscles to get the information we need. That is not in every patient. Every patient will not always receive all the things that you see here, but as deemed necessary, we will do it. Carotid ultrasounds, Again, we are looking at all the vessels. We want to know, are your vessels healthy? What is the reason this patient has a stroke? And sometimes we need to use, again, same carotid or same ultrasound technology to take a picture of the vessels of the neck to get that information for you. An EKG. This one monitors electrical activity of the heart. Is electricity conducting through your heart and helping it to beat the way that it's supposed to be? We are looking for irregular conduction or irregular beats in the heart. One of those things we're looking for most often is AFib. If a patient has atrial fibrillation, that significantly increases their risk of stroke. And if a patient comes in with a stroke and is found to have AFib, that will absolutely alter the management that we have for them to prevent strokes in the future. Labs. You come into the hospital, everyone is doing tests. We're sending you here, taking pictures there, but we also need to test your blood. This helps us find out, is your cholesterol too high? Your A1C, that's a test to tell us if your blood sugars have been in a normal or abnormal range for the last 120 days. Medication efficacies. So if you're taking medications like aspirin, Plavix, Brilinta, Coumadin, and many other ones, but these are the primary ones that we test for here. We want to know, are they working? Many patients will come in, they have a stroke, they've been on this medication, and they tell us, I have been taking my medication, I never ever miss a day of it. And we check the efficacy of it, and they're just not a responder to that medicine. That is important information. Or patients come in and say, hey, I haven't been taking it, or I'm not sure if I took it. Again, this test will help us determine what medication changes may need to be made. Kidney function. If you come into the hospital and you have abnormal kidney function, it changes the management at the door. Not able to do a CTA. However, if you come in and you get contrast, sometimes your kidneys can, not like it so much. But we do things to mitigate that. But we also want to keep an eye on them. We also want to know if your kidneys are working well, because if they're not, also a risk for hypertension. So every lab test that we draw is usually important and gives us crucial, critical information to help take care of you. And not all the time, but some patients will get what we call an hypercoagulable workup. That workup is for patients who we have had a reason to think that they may have a higher risk of developing clots in their body, or they've had abnormal doors that shouldn't be there, and we want to make sure that their body doesn't send a clot through one. So these are some of the things that we would do here. Again, this list is not all-inclusive, and it does not apply to every patient that we will see, but it's important that we discuss it ahead of time, just to give you a glimpse of some of what we do. Stroke treatment for ischemic strokes, again, there are medications called clot-busting medications in general terms, but they are called IV thrombolytics. Some patients may know of them as alteplase or TPA or tenecteplase, T&K, but those are some of the medications being used right now here at Riverside. We are using this medication when it is indicated, and one of the things that we need to know are the onset of symptoms and the last known well. This medication is safely administered in most cases up to 4.5 hours from the onset of symptoms. Outside of that window, or in a prolonged window, it increases the risk of bleeding in the brain from the medication. So all the things we do are not without risk, but we want to minimize the risk as best as possible. So safely, we will give this medication if a patient is indicated to have it. There are things called intra-arterial reperfusion therapies and revascularization therapies. Those are what Dr. Ramakrishnan and Dr. Leach are able to perform to help remove clots from the brain, or to go in and take a peek more closely and see if there's something that they are able to fix to reduce your risk of having a stroke in the future, or to undo the effects of the stroke itself, or the cause of the stroke itself, sorry. Neurovascular intervention, similar thought process, but they are able to do so much when it comes to the blood vessels. And if they're not able to do any of these aggressive things, so we're not able to give you clot-busting medications, maybe because you went to bed normal and you woke up with the symptoms, and we can't tell if it happened 4 hours from now or 10 hours from now. Or we don't see anything that's blocking a blood vessel for us to go after. That's the reason we wouldn't do this. Or there's no other immediate need for a procedure, then we will manage you medically. So that would mean optimizing your medications, controlling your blood pressure, controlling your diabetes, making sure you're taking a cholesterol medication to lower your risk there. So there are different ways that we would treat an ischemic stroke. And not all of them require procedures. Many of them don't. A lot of them are just really looking at, again, those risk factors that you may or may not have and optimizing, making sure we are doing everything we can to minimize your risk by taking care of the things we know are right in front of us. So this is just a picture, some pictures that I was able to put together to give you an idea of some of the types of procedures that we're able to do. Again, I'm not a proceduralist, but I do work closely on the team, and I help manage these patients. So in the top left one, you will see where that arrow points. There's a blockage there in that blood vessel. If you think a few slides over when we took the picture, that is what we look like, what we look for. If we see a blockage, then you would go into the procedure with our attendings, and they will take direct vessel images of the vessels in your brain, and they're able to see that clot there. If they see that clot, then they will do what they can to get it out, right? Again, a lot of these things are time sensitive, and it's not you have a clot, we go in and we take it out. We want other information. When did it start? Is there enough penumbra to be saved? Will it be more harm than good? And these are all conversations that will be had with the patient and with the patient's family when it comes time to make these critical decisions. So although we're discussing it, understand that every procedure is not going to be for every patient, and every case is not going to be the same, but we modify what we can do to make sure we have the best outcomes for the patient. In the picture to the right of it, you see after they were able to remove the clot by whatever measure or whatever technique they did, they were able to open those blood vessels back up, and now the part of the brain that was starving for blood and oxygen no longer is. If you move over, you see this is a picture of a carotid artery under, again, the same diagnostic imaging, what we call cerebral angiography. There is a blockage here in this carotid artery, okay? And if you look in the picture to the right of that, then you see where there was a stent placed. It's hard maybe to see if your eye is not trained for it, but you can definitely see that there was something that was narrow there that now is not. Over to the top right, this is a picture of a stent retriever. So it's a type of procedure that the doctors will be able to do where they go in, they use this special type of wire and catheter to pull the blood clot out of the vessel itself. And again, at the bottom, these are just some images to let you know the pathways and the ways that they are able to travel up vessels to get directly to where the clot is and pull it out, either by way of what we call stent retriever, so they're able to go in and a mesh traps the clot and they're able to pull it in, or by suction, where they send a catheter up and they're able to suck onto the end of the clot and pull it out itself. Again, every case is going to be different, and the hope is that we have full success with it. But the goal is to minimize risk and increase the chance that we save as much penumbra and not leave patients with debilitating effects of a stroke. After these things, you come into the hospital, and then we continue to work with you. We continue to treat you and make sure that we're doing everything we can to get you through this very, sometimes for patients, traumatizing time, but understanding that we are the experts here, and we want to do what's best for you. So stroke treatment for hemorrhagic strokes, again, there are strokes, bleeding that occurs within the brain tissue. This would require us to control your blood pressure. If a patient comes in with an incredibly high blood pressure, or sometimes just a high one, higher than normal, the first thing we're going to do in most of these patients is control that. We want to make sure that if there is a pipe that is leaking, we want to decrease the amount of flow that's coming out of it. So we need blood to get to the brain, but we don't want it to do it under high pressure and make that bleeding worse. And then if you're taking blood thinners, we may have to give reversal agents so the effects of those blood thinners don't work, or we just won't give you any more. You can be found to have an aneurysm, again, through some of the diagnostic testing or some of the AVMs, or be found to have an AVM. And for each of these things, there are, again, different types of procedures that may be offered to some patients to treat it. In this slide, this is a picture of an aneurysm on the left, and it shows where there is that abnormal outpouching of the vessel. So the vessel wall gets weak, it forms a little bit of a bubble, and then too much pressure and it may rupture, or the blood vessel wall itself just gets weak enough and it reaches a point where it bleeds. This is one of the treatments that they will do. Again, not a proceduralist, but well aware of what it is that my attendings are able to perform. And here they take what is these little wires called coils, and they're able to pack them into the aneurysm itself and cause a basket to form. When that basket is formed inside of the aneurysm, it doesn't allow blood to swirl inside of there, and therefore the aneurysm itself will die off, and it reduces the risk and hopefully eliminates the risk of bleeding from that aneurysm again. So this procedure may be done for some patients, again, not all, but based on risk and what the risk benefits of it and where this aneurysm may be located and what exactly can be done. This is one procedure. So it may be done where a basket is just placed, and then there are some situations where they place a basket of wires, but they need to make sure that that basket stays in place. So they use a stent or a stent-assisted coiling is what you see here on the top right. So they put a basket of wires in there and then a stent across it to make sure that that coil stays in place. It allows blood to still flow through the vessel and to feed the vessels that are coming off of that primary one, but the coils are able to go in place to reduce the risk of that aneurysm bleeding again and to eventually kill off the aneurysm, okay? And then the bottom right one is flow diversion. So in this situation, you don't put a basket of wire into the aneurysm. You just keep blood from going inside of it. And eventually, if that aneurysm does not get any blood supply, then it eventually will shrink and die off. So those are some of the different things that they can do to treat aneurysmal hemorrhagic strokes. But again, there are many different procedures that they would do for AVMs. There are different types of embolizations where they take it and they kill off they seal off some of the vessels that are feeding those abnormalities. But again, these are just to kind of surface touch on some of what we do here. So after the stroke, you suffered a stroke or your loved one suffered a stroke, now what? What can you expect from us? You expect general tests to be performed. You expect to see us every day. We come in and we do neuro assessments. You, as a patient, they become well versed in what we ask them to do. So much so that it becomes repetition, but it's helpful because the clinical examination is what is our first indicator that something may be changing with a patient. So if we come in to see you today and your arm was able to, raise and not touch the bed, and now today you can't raise it off the bed, makes us wonder or, have a conversation about what exactly is going on. So you will expect lots of visitors here in the hospital, from the medical staff, the nurses, the lab technicians, the consulting teams, dietitian, housekeeping. You're here in the hospital. We are trying to provide an environment of healing. Again, treatments, time is brain. You suffer a stroke, get to the hospital. Do not wait, come in. And the faster that we do these things, the more likely we are to reduce the area of brain that's going to be damaged from it. That is our ultimate goal. Therapies, physical therapy, occupational therapy, speech and language pathology. Physical therapists are going to help you with those gross motor skills, the things that you do like walking around and being able to sit, stand, go from the bed to the chair. And occupational therapy thinks more of the fine motor, how you eat, how you hold a fork, how you hold a cup. They're going to be there to evaluate you and see what types of deficits remain from your stroke. Speech language pathology. You come in with slurred speech because the muscles of the tongue and the throat and the mouth may be weak, so you're not able to coordinate that movement well enough to speak, and therefore maybe not even swallow. So you may need some assistance and evaluation with that. And, if your speech is just altered, the speech language pathologist can also help with that. You're going to need family and support systems. A stroke is a very humbling thing for many people because you lose somewhat of your independence and you become relying on the help of healthcare providers to help you through it. So understanding that support systems are going to be one of the better things that help you while you get through this process. After the hospital, some patients are fortunate and lucky enough to go home with home health therapy, but that's not everyone else. Some patients may need long-term post-hospital care, so acute rehab or skilled nursing, long-term care nursing homes. Those are things that are put in place to help a patient in the post-hospital recovery. And then staying in the know, be informed, ask questions, use reputable sources, which we're going to get to in the next slide, but understand that we welcome your questions. We welcome the opportunity to teach you. And if you have questions about what's happening in your healthcare, you should know. And as a family member, if you want to better understand what's happening with your loved one, same thing. So this slide here, this one just goes over some of the resources that we have for stroke survivors and for loved ones. These are known sources. These are ones that if you were to say, okay, I want to get some good, solid information, these are the ones that have been found to be reputable. You want to use sources that are current, that are up to date, and that are using science to really drive what it is that they're doing. And for more information about stroke, different organizations you can reach out to or go to their websites are the American Heart Association, American Stroke Association, Centers for Disease Control and Prevention, the National Institute of Neurological Disorders and Stroke, National Institutes of Health, and Medline Plus. So those are just some, not all. Up to Date is another good one. So we just recommend, no Dr. Google. We are here to help you, and we're here to provide you the information. When you come into the hospital, you ask us, we'll put you in the right direction. So let's recap. So stroke, what is it? It is an event that occurs when blood and oxygen is not able to get to an area of the brain, and therefore that area of the brain is injured or dies, and it is either an ischemic stroke, a blockage type of stroke, or a hemorrhagic stroke, a bleeding type of stroke. What is a TIA? Not a stroke, but it is also not a mini stroke. A TIA is a TIA, and a stroke is a stroke. But a TIA is just as important. 500,000 people every year suffer a TIA, and up to 17% of those patients come in with a stroke within 90 days. So don't take a TIA lightly when you have symptoms come to the hospital. Who is at risk? Anyone can be at risk. It is not an age-specific disease. Patients under the age of 65 may have a stroke, and as your age increases, you may have an increased risk of it. But how can you prevent it? Modifying risk factors as able. The things you can do something about, do. Control your hypertension, your blood pressure, your blood cholesterol, diet, exercise, making sure if you have chronic conditions, you keep up with your medical providers. Keep an adequate, up-to-date list of medications. Be in the know, stay aware. BEFAST, remember? Those are your stroke symptoms. Balance, eyes, face, arms, speech. Any of those things are affected, you call the hospital, you call 911 immediately. Do not drive to the hospital. Do not get a ride. Do not call a cab, or Uber, or Lyft. You call 911 and you let the emergency professionals come and evaluate you and bring you into the hospital, okay? Stroke care, we talked about a lot of the things that we can do here. And again, it is not a one-size-fits-all. Every patient is different. Every patient's deficits are different. Every patient's recovery are different. The one thing that stays the same is the level of knowledge and expertise that we use to serve you every day. After the stroke, you can either be expected to go home or go home with some therapy or need some longer-term care, but understanding that all of those things in place are to help you recover from the stroke you may have suffered. And finally, know your resources. Use reputable sources and stay in the know, stay current with the information, and attend talks like this. Okay, and so we are at the end. This is just my information again, Jatifha Harris, and again, the other nurse practitioner is Kaylee Zapata. She apologizes again that she could not be here, but she is still in the hospital taking care of our patients. The contact information there that you see is accurate for the both of us. So if you ever needed to reach out to us, this is how you would be able to find us. I believe that is the end of my talk here. So I can get out of here and get to the chat. I just want to make sure, Kylie, is that correct?
Yep, that's correct. So if you have any questions, please enter them in the chat and we can get those answered for you.
Did I close it? Kylie, am I still sharing? I just want to make sure.
Yeah, it looks like you're still sharing. So if you go up to the top and hit stop share, yep, there we go. Perfect.
Thank you so much. Okay, let's see. I think I'm looking. I don't really see any questions from anyone. So if you do, I'm here to answer any of the questions that anyone may have about some of the information we discussed here. Minutes. Here we go. Okay, while a patient is going through stroke imaging when they first enter the door, what is being done to preserve the penumbra? That's a very good question. So when you come in, the main thing that we're doing to preserve the penumbra is time. We are moving fast. We want to make sure that we move things at a very quick pace, and that is what it is. So time is brain is what we're doing to preserve the penumbra. We allow things to kind of settle where they are when they come in. So sometimes patients will come in with a high, or elevated blood pressure if they have an ischemic stroke or a blockage. So we don't immediately lower the blood pressure because sometimes that helps give blood and oxygen by way of pressure and delivery to that area of the brain, but again, case by case. The best thing we can do to preserve and save and help the penumbra is move quickly, call 911 immediately, and move quickly at the door. Are there tests? Can you get tested for stroke prevention? Not specifically stroke prevention, but you can get tested for your risk factors. So seeking routine medical care, going to your primary care doctor, routinely checking your blood pressure. Hypertension is one of the leading causes of stroke, and patients who are found to have controlled blood pressure are less likely to have a stroke. If you have diabetes and hypertension, then your blood pressure, your risk for stroke also elevates. So the things you can do as far as getting tested are monitoring your blood pressure. If you are a diabetic, routinely checking and making sure your blood sugars stay in control. Have high cholesterol, getting a lipid panel checked and having medications or diet adjustments to help bring down the cholesterol levels, which are a direct risk factor for stroke. Those are the primary things, but a direct test for stroke prevention is not, but we can test for risk mitigation or risk modification, so to speak. Again, one thing I didn't mention, smoking. Do not smoke. Smoke is, again, one of those things that can increase your risk of having a stroke, and somehow that was not in the presentation, but again, that is a modifiable risk factor. Any type of smoking, cigarettes, cigars, or illicit drug use, drinking, all of those things can add to stroke. So although you can't directly test for them, you can risk modify. How long does it take to get a CT-CTA? So that depends. So a CT is a very quick procedure. We put you in the scanner. It spends maybe about a minute and 30 seconds, but it's not just the scan that takes time. It's getting you from the ER, getting you with the staff, getting you on the bed, transporting you to CT, getting you on the table, asking more questions, verifying who you are. So a lot of times the setup for the CAT scan is what takes more time, but the CAT scan itself is a little quicker, as well as the CTA. The CTA, again, is going to be patient dependent. Are you eligible to receive the CTA? If so, you would need to have an IV placed. That may take some time as well. But again, those tests, usually within minutes, patients are on the table and we get the images up within sometimes 5. MRIs do take a little bit longer. It depends on the type of MRI you're getting, the type of sequencing. Is there going to be some kind of contrast given with it? But they do take much longer. So CTs within minutes, MRIs 15 to 30 minutes, maybe a little bit longer than that. These are good questions. Thank you. What can AFib patients do to prevent TIA and stroke? Honestly, working with your cardiologist and your primary care team. AFib patients are at risk for stroke because the heart does not pump appropriately. So the blood quivers a little bit. So what should happen is a good, strong pump of the heart. And in the AFib, it quivers. And when it quivers, blood does not get ejected from the heart in one fell squeeze, right? So blood has time to swirl around, and where things swirl around and get stagnant, blood clots can form. If a blood clot forms in the heart from AFib, it can be directly pumped out of the heart into a vessel in the brain. So the best thing you can do as an AFib patient is work with your cardiologist, who may recommend anticoagulation, which is blood thinning medications, if you are deemed safe for it and don't have any other risk factors. There are certain procedures that can be done to put maybe a cage there to keep the clots from being able to from being able to be ejected from the heart, because they typically form in a very specific part of the heart. And so sometimes they'll put a small cage there to keep those clots from flying out. Taking your medications, controlling your heart rhythm and your heart rate, working with your cardiologist, and finding the regimen that is appropriate for you is going to be the best thing an AFib patient can do. And again, everyone's risk and benefit is going to be a little bit different, but if you're working and keeping up with your cardiologist and your doctors, they're going to be the ones who are going to help you the most prevent a stroke. Let's see. Does having an A1C of 5.6. So when we think about diabetes, the A1C helps us understand the trend of your blood sugars, right? So if you get an A1C done and it's less than 6, you're considered to be at lower risk. But the only thing that tells us is that your diet is not high in sugar. It does not tell us that your diet is healthy, right? So it is just one key piece of the information there. If you have an A1C that is elevated, then that means not enough is being done to control your blood sugars on a long-term basis. So 120 days is about how much the A1C can capture. And if it's elevated, that means they've been high for too long. And if they're lower, less than 6 usually, means that you have a blood sugar that's usually within normal range in the last month preceding when you had it tested. But keeping a close eye on it as a diabetic, keeping a close eye on your A1C as a diabetic lets you know that the strategies you are using to keep your blood glucose in control are working. So it's important to keep those up. You do want to have a lower A1C, but along with maintaining a low sugar or, keeping your diabetes in control and not having a diet high in sugar, you also want to make sure it's not high in saturated fats, cholesterol, salt, other things that can give you other problems. What percentage of stroke survivors return to normal or functioning? So that's a very difficult question to answer because understanding that everyone's deficits or everyone's definition of normal or functioning is going to be different. So some patients like to ask, did I have a big stroke or did I have a small stroke? And really, you can have a very small stroke that hits a specific part of the body that gives you more deficits than a larger stroke. So really what we look at is, what were the symptoms of your stroke? What are your goals? What is long-term? What is it that you want to be able to achieve? If today you can't raise this arm off the bed, maybe long-term you're able to raise it up, maybe not full strength or mobility, but everything is going to be very patient-specific. What we like to think is that within the first 3 months or so, that is when we see the most recovery in our stroke patients. After that point, it's not that recovery stops, it just does not happen at the same trajectory as it does when you first have the stroke. So again, every patient is a little bit different, but we like to say we give patients at least 3 months to see where they're going to end up with it. And understanding what is normal functioning is going to be different for every patient. Some patients are like, I am fine if I have a little numbness here, as long as I'm here. Some patients are like, no, if I have to use a cane or walker, that's fine, but I'm here, I'm able to talk, so it's very different for every patient. Is it likely to have a second stroke after the first? Yes. So I think in one of the slides I said 17,000 about patients have a first-time stroke, and then 26,000 patients have a stroke the second time. So if my numbers are, not mismatched, but I want to say, yes, if you have a stroke, you are at risk or more likely to have another one. But that's just by nature of risk, right? So if you have high blood pressure, high cholesterol, diabetes, obesity, sedentary lifestyle, and those are things that we can fix, but sometimes the damage that's done from those things are already there. So we can't undo some of what happens. We can just prevent it from getting worse. So if you have any of those risk factors, the things and the changes are already happening in your body. And again, what we're trying to do is prevent the rest of the fire damage, right? So we want to stop it where we see it, but we can't undo what was done back there. So yes, you can. You are at risk of having another stroke once you've suffered your first. I'm just gonna back to that screen so I can tell you exactly the number. So yeah, so 17,000 patients have a first-time stroke each year, and then 26,000 people suffer a recurrent stroke, here in Virginia at least. Those are really good questions. I think that's about all I see. I think I've scrolled through all of these. Those were the ends of the questions that I see here. So this was, I'm so happy to present and give you a glimpse into what we do here every day. We love what we do. We love taking care of patients, and it is our goal to reduce the number of strokes that we see every year and to reduce the number of patients that come into the door, and to give you the information that you need to not only prevent yourself from having a stroke, but to be aware of what may happen if you do. We want to help build confidence in our community and in the people who are served here at the hospital to understand that our program is dedicated to providing high quality care that is comprehensive and skilled in nature, and that we're all here to, play a role in that. So I think that is about it. Haley, are we